Clinical chemistry, calcium homeostasis. Serum calcium is maintained at a constant level. Cellular and tissue effects of calcium depend on the blood calcium maintenance with a specific range. The adult human body contains 1,000 grams of calcium. 99% is hydroxyapatite salt. Hydroxyapatite's talking about the bone matrix, so it's making up the bone tissue. And 1% in extracellular fluids. Diet is the only source of calcium, and urine is the only significant way out. So this is a diagram showing calcium homeostasis. So dietary calcium is the only way that we can get it into the body. So either we eat it directly in the diet or take supplements. Then we have intestinal absorption, and then we have our blood calcium levels. From our blood calcium levels, it's then either deposited in the bone or it's excreted as a waste product through the kidneys. Vitamin D is a steroid hormone that is synthesized in the skin following exposure to UVB rays from the sun. Vitamin D3 is scarcely found in nature. The major dietary sources are internal organs such as liver and seafood. Tissues involved in synthesis include the skin, liver, and kidneys. Tissues it affects includes the gut, bone, and parathyroids. De novo synthesis begins in the skin, where 7-dehydroxycholesterol is transformed into vitamin D3 by the action of UV light. Can also be obtained from dietary sources, fortified milk, multivitamins, cod liver oil. So the skin takes 7-dehydrocholesterol and turns it into vitamin D3. Vitamin D3 is then converted to 25-OH vitamin D, and 25-OH vitamin D in the kidney can then convert it to its active metabolite, 1,25-OH2 vitamin D, and that's going to have tissue-specific responses. Parathyroid hormone is secreted from 4 parathyroid glands that are behind the thyroid gland. The parathyroid glands have calcium-sensing receptors that respond to calcium levels by increasing or decreasing parathyroid secretion. The function, it stimulates bone resorption and the release of calcium into the blood. It acts on the kidney to increase the reabsorption of the renal tubular calcium, so we're going to reabsorb the calcium to keep it in the body. Increased phosphate excretion, and enhanced 1-alpha hydroxylation of 25-hydroxy vitamin D. All functions raise blood calcium and are mediated via a specific PTH receptor. GI physiology. Factors required for calcium absorption. So normal intestinal function, short bowel syndrome, and genetic or physiological defects may have a negative effect. Adequate dietary calcium intake, normal vitamin D availability, and metabolism. The role of the kidneys. Diseased kidney impairs calcium metabolism. Hypercalcemia, whether it's as a result of autonomous overproduction of PTH, termed primary hyperparathyroidism, or from other causes, increases the filtered load of calcium. It increases the chance of the formation of calcium-based kidney stones. Bone turnover or remodeling is a coupled process of simultaneous bone formation and breakdown occurring throughout life. Bone formation is mediated by osteoblasts. Bone breakdown or resorption is mediated by osteoclasts. When resorption exceeds formation, bone mass decreases, and that causes an increased risk of fracture. There's 2 main types of bone in the skeleton: cortical, which is primary type in long bones, it's the femur, strong, rigid. And then there's trabecular, which is found in the axial skeleton, the vertebrae, and has many crosshair type connections, trabeculae, providing strength and elasticity. Hypercalcemia. Hyper means more. Ca is the element symbol for calcium, so hypercalcemia. Blood calcium levels are above the expected normal range. Binding of calcium to other substances must be taken into account when considering total calcium levels. A patient with low serum albumin would be expected to have a low total calcium and normal ionized calcium. Opposite is true for patients with high serum albumin. PHPT, primary hyperparathyroidism, is most common cause of hypercalcemia in outpatient setting. So other causes include secondary and tertiary hyperparathyroidism, CSR, calcium sensing receptor abnormalities, other endocrine disorders, cancer-mediated hypercalcemia, granulomatous disease, medications, and renal disease. Endocrine causes of hypercalcemia. Primary hyperparathyroidism, again, is the most common cause of hypercalcemia in an outpatient setting. A physiologic defect in the parathyroid glands themselves, resulting from adenomas or hyperplasias of the parathyroid glands. Hypervitaminosis D. It's caused by excessive intake of vitamin D or aberrant production of 1,25-OH2D. Cancers, PTHRP tumors, cause of release of hormones or hormone-like substances. Signs and symptoms. So in the CNS, you see lethargy, decreased alertness, depression, confusion, forgetfulness, obtundation, coma. GI, there's anorexia, constipation, nausea, and vomiting. Renal, it impairs the kidney's ability to concentrate urine, leading to dehydration and an increased risk of kidney stones. Skeletal, increased bone reabsorption or bone resorption, increased bone demineralization, and risk of fracture. Cardiovascular, causes or exacerbates hypertension. Biochemical findings in PHPT: hypercalcemia, hypophosphatemia, elevated PTH, low normal 25-OHD, and high normal or elevated 125-OH2D. Urinary calcium excretion is elevated, metabolic hyperchloremic acidosis, hyper, again, more, chlor is talking about chlorine or chloride ion, acidosis is talking about the pH of the blood drops. Elevated serum alkaline phosphatase in severe disease. There's familial hypocalcemuric hypercalcemia, which is a benign condition where there's a germline mutation of CSR. Stable, mild hypercalcemia from birth, and hypocalciuria. Serum calcium is elevated, and serum magnesium is mildly elevated. PTH is mildly elevated. Urine calcium levels are typically less than 100 mg in 24 hours. Mutation in CSR can be demonstrated. End organ dysfunction, bone and kidney, is uncommon, therefore surgery should not be performed. Other causes: hyperthyroidism is an increased resorption in hypercalcemia. PTH levels are low. Addison's disease is another one, the Addisonian crisis. PTH levels are low. It gets corrected promptly with fluid and steroid replacement. It is thought to be a result of hypovolemia and dehydration. Organ system cases of hypercalcemia. Milk alkali syndrome results from an ingestion of large amounts of calcium together with an absorbable alkali. PTH level is low. Renal failure. So renal excretion of both calcium and phosphate is severely impaired. Production of the active form of vitamin D is limited, and PTH secretion is stimulated. Medications that can cause hypercalcemia. Thiazide diuretics, so used to treat hypertension. It causes retention of glomerularly filtered calcium. Lithium is used to treat bipolar affective disorder. It appears to shift the set point at calcium sensing receptor. Vitamin A is believed to activate osteoclasts and enhance bone resorption. Elevating blood calcium, PTH, and 1,25-OH2D are suppressed. Hypocalcemia. The state of blood calcium levels is below the expected range. It's best measured by ionized calcium. Signs and symptoms: neuromuscular, you have tetany in the hands, so clenching and uncontrollable contraction of the hands, feet, legs, and back. Schaffstett's sign, numbness and tingling in the face, hands, and feet. CNS, irritability, seizures, personality changes, impairment, intellectual functioning. Cardiovascular, QT prolongation, electromechanical dissociation. So if we think about the role of calcium in the body, calcium isn't just here to help build strong bones. Calcium is here so that we can have muscle contractions and a heartbeat, and calcium helps regulate the electrostatic environment inside of the body. It's an electrolyte, and it serves a whole bunch of different roles. So if we don't have enough calcium, we're not able to stop muscle contractions, and we're not able to have proper nerve impulses and all sorts of other things. Endocrine causes, so hypoparathyroidism or lack of PTH, postoperative, autoimmune, congenital, and pseudo-hypoparathyroidism types 1A, 1B, and 2. A deficiency of vitamin D due to malnutrition, malabsorption, weight loss, gastric surgery, short bowel syndrome, abdominal irradiation, pancreatic disease, liver disease, and renal disease. Hypomagnesemia. Magnesium depletion leads to a lack of PTH synthesis and release. Endocrine causes of hypocalcemia, so hypoparathyroidism as a result of neck surgery, autoimmune destruction, mutations in the PTH gene, abnormal deposition of copper, aluminum in parathyroids, magnesium deficiency. And there are several others listed. Organ system causes of hypocalcemia, intestinal disorders that result in inadequate calcium or vitamin D absorption, renal insufficiency or failure, and then genetic defects resulting in an impaired ability to recover filtered calcium from tubular fluid. Medications that can affect calcium metabolism, anti-resorptive agents, medications that stimulate bone resorption, lithium, thiazide diuretics, and recombinant human parathyroid hormone. So now we're going to talk about some of the metabolic bone diseases. So rickets and osteomalacia. Rickets and osteomalacia are basically the same disease, except rickets is in children and osteomalacia is in adults. It's caused by abnormal bone mineralization and vitamin D deficiency. Osteoporosis is the most prevalent metabolic bone disease in adults. It affects an estimated 20 to 25 million Americans, with 4 to 1 female to male predominance. It's believed to cause 1 to 1.5 million fractures annually in the United States. Diagnosis is based on clinical characteristics and/or a DEXA scan. Fragility fracture, the fracture occurs at inappropriate degree of trauma. Treatment, it's directed at the primary consequence of the disease, so the fracture. Modification of preventable risk factors such as smoking and alcohol consumption. Evaluation of fall risk. Consideration of walkers, handrails, nightlights, hip pads. Adequate dietary calcium and vitamin D. Prevention for those with family history. Minimize bone loss, increase bone density, and prevent fracture. And then there's also medications.